Hi friends, very warm welcome. Please give me a thumbs up if I'm visible and audible in the comment section. Just type in yes if I'm visible and audible. I hope all of you have I hope all of you are able to see me and hear me. If everything is fine, please do give in the comment section. Please do comment yes if you are able to see me. Yes friends, so please just comment or else I will just. Okay, I think audio and video are working fine. Yes. So, hello friends, myself Dr. Srinivas, your dermatology educator on Unacademy platform. So, today is the day when most of the students have finally got the relief from this particular NEET exam. NEET exam after so much of dramatization happening around. So usually the exam has to happen in the January month, but it has been dragged on, and it's almost the next year NEET. By this time at least I'm happy that it is completed, otherwise it would have been a lapse of an year. Okay, and I hope everyone of you also is able to feel shy of relief. Okay, please give a thumbs up if you are at least feeling the shy of relief at this moment. Yes, nobody has commented a single comment. Please do put whatever you are feeling in the comment section so that I will get to know that students are actually watching this, and this is the time actually whatever you have to mark, you have marked it already. So don't worry, don't get tensed up so much, because whatever you do, that's not going to change whatever has happened. So just feel happy that you have crossed one barrier, that is ability to uh, feel the tension and sustain the tension and pass this particular stage, okay, without getting any panic attacks or anything, most of the students. And one small disclaimer, so these are recall MCQs. So I have not written the exam myself in the exam hall, so maybe there is a possibility few points maybe plus minus, okay, but there may be some mistakes also which you must all accept, and if there are any such mistakes, please do point out in the comment section. So in the live video, I will try to make the changes, and I will share this particular whatever questions I am discussing, I will share it in the Unacademy group, okay. And also these are very important for the upcoming exams, and I have seen few students who have actually messaged me and they told that they are going to start their preparation for INSCET exam from tomorrow itself, okay. So by that time, the results and the counseling process of this NEET exam is concluded, INSCET exam will be there. So my suggestion for all of you would be, take some gap, okay, whatever you feel is apt for you, take some gap, but I would suggest you to continue your preparation, whatever momentum you are having, just continue that for some more time. So 2 or 3 months max, you are going to get the INSCET. The dates are not yet announced, but definitely uh, it is going to be 2 or 3 months, by the time which most likely counseling process also would not complete of NEET exam, okay. So I would suggest you all take a chance and write the INSCET, because and one more thing, this exam, most of the students felt that they thought that instead of 300, because 200 questions are going to be asked, they will be very lengthy, okay. Even many of us also thought that, but contrary to the whatever we thought, So everything was clinical, but the questions were not so much lengthy. So this was what I got, not only from my subject but all other subjects. If you also feel the same thing, please do give a thumbs up in the comment section or for this video, okay? And maximum questions were 2 to 3 lined, and most of the questions were actually repeats with slight modification in the question, because of which few students felt maybe the question is tricky, so they have thought more, and they marked, some of the students they marked wrong answers. Okay, this can happen sometimes. Okay, this has been seen happening over the past, and it is going to happen now, and even in the future this is going to happen. And these are actually the codes. If you scan this, you can watch all these 2020, 2019, 2018 NEET PG videos also. So I will discuss about these things. So you might be in a hurry to actually watch this thing. So this was before the NEET exam, where I thought actually the opponent. So one of these is you, and the other one is the opponent NEET PG. I thought the NEET PG opponent is going to be as strong as you, but many students felt that it was okay, average kind of a show. Yes, and this was what I told. Victorious warriors win first and then go to war, while defeated warriors go to war first and then seek to win. And also, every warrior wants a worthy opponent. There is no redress in fighting the pathetic. Sometimes, you will understand the importance of this when you get the results. If at all really what students felt is true and this question paper was easy, then for 1 mark there is going to be a lot of aggregation, a lot of pooling, and this is even if you make a small silly mistake, that is going to make your rank deteriorate by 1000 or 2000 or 5000 ranks. Okay, so that is the problem if the question paper is really very very easy. Okay, and always, yes, whatever may be the case, you should always think that I can do it. This should be the positive attitude. Okay, yes. Now with that note, please try to answer this question, what you all have felt. Please put your answer in the comment section. Okay, I'm checking out the options which all of you are actually putting. Yes, crazy links. Yes, sometimes it can happen. Panic attacks can happen. Okay, Darshan says amoxiclav. So those all the students, please, even those who are watching this in the final year or in the internship, maybe you might also be watching. Try to attempt it, whatever you feel is correct. No problem. Even if it is a mistake, that is okay. No problem. Because in the real exam itself, students have marked already, so that doesn't matter anything. I am not any NB board or AIMS board, so that is okay. So I can see maximum students are actually giving the correct answer, which is option A, amoxiclav. So first of all, this we can say actually a little bit of integration with microbiology and dermatology, little bit. Okay, so first of all, the question is telling finger is having paronychia. So what does paronychia mean? Paronychia. So onychia, wherever it is there, it is related to nails, and paronychia is surrounding the nails. So what is paronychia is basically in the nearby the nails there is going to be a inflammatory process. Whenever inflammation happens surrounding the nails, that is over the proximal nail fold and the lateral nail folds, we call it as paronychia. So that inflammatory component is mentioned, and along with that extensive wheel like infection pattern, linear pattern is there. So I hope this was the same image, or at least this was almost the same image. Please give me a thumbs up if this was the exact image, or if it was something different, you can put it is different. Okay, so this kind of a picture is shown where there is a linear pattern of erythematous change which is shown in the image. So you need to integrate both of these concepts, then only you can come to the final diagnosis. Okay, paronychia, again it is of two types. So paronychia, it is of two types. So number one is, one second, this color is I think very this may be better. So it is of two types, acute and chronic. So acute and chronic. Okay, so chronic C for C, chronic variety of paronychia, it is usually it is going to be persistent for a period of more than 2 months. Okay, and the most common causative agents are Candida and contact dermatitis. So C for chronic paronychia and C for Candida or chronic dermatitis. Okay, and acute variety of paronychia, it is caused by bacterial infections. Acute paronychia is caused by bacterial infections. And if you see in this picture, you can see that the acute variety, you can see the presence of inflammation surrounding the nail plate, and you are able to even see the pus. And acute, which is bacterial, is most commonly caused due to Staphylococcus aureus, but also even Streptococcus also can be one of the cause. Streptococcus also can be one of the cause. Okay. So if you take that into consideration in the infections, bacterial infections of the skin, we have this pyodermas, out of which erysipelas and cellulitis are very, very important. And if you look at the erysipelas part, which is actually superficial infection when compared to cellulitis, where the infection is going to be present in the upper half of the dermis, and there will be involvement of the lymphatics mainly in erysipelas. Okay, and if you look at the causative agent in erysipelas, you will understand that it is group A beta hemolytic streptococcus. This is the only causative organism for erysipelas, and this is going to even involve the lymphatics, and this is the reason of because of which the bacteria which is responsible in this case is streptococcus, because of the image which is showing that lymphatics are having the inflammatory change. So we can think of streptococcus, and among the given options, amoxicillin, which is a which belongs to penicillin group of drugs, this is going to be effective against streptococcus. So that is the reason why answer for this question is amoxicillin. Okay, I hope everyone has understood this. And please give me the answer for this question. So a truck driver came with the complaints of painless genital ulcer after unsafe sexual intercourse. Motility of the causative organism can be best checked by which type of microscope? Okay, almost same. Good, fine, fine. So the most important thing is the pattern, the linear pattern which you need to appreciate in the particular picture, which is actually pointing towards a lymphatic spread. And similarly in dermatology, lymphatic spread is also important in one more deep fungal infections, that is sporotrichosis. Okay, this is slightly off the topic actually. Sporotrichosis also has this linear lymphatic spread. So here I think every student has answered this right. Very good. So starting from the first this truck driver, everything is a very easy clue. Truck driver, IV drug abusers, or male, commercial sex workers. So all of these are actually very high risk behaviors for sexually transmitted diseases. Okay, so this is number one clue. And complaints of painless genital ulcer. So it is already mentioned that there is a ulcer over genitalia, and the characteristic of this ulcer is painless. This is extremely important clue which is given. And there is unsafe sexual intercourse, that is without usage of condom. So motility of the causative organism can be best checked by which type of microscope? Okay, so if you get to see this kind of a picture where the ulcer is painless, was there any other clue which is given in the question? If yes, please give me the thumbs up. Yes, friends, was there any other clue given in the question? Okay, motility, yeah. So motility, type of the motility, was it given in the question? Okay, Priya Chauhan. Oh, indurated ulcer was given. So was it mentioned that the ulcer is indurated, painless indurated genital ulcer? Friends, yes, just type yes if it was given as indurated. Okay. Yes, sir. Okay, thank you so much. So if induration is also given, then it will be actually a very straightforward question. That is a genital ulcer which will be painless with induration. That is button-like induration. This is going to point out towards a diagnosis which is syphilis. Which is going to point out towards syphilis, and syphilis, the causative agent is Treponema pallidum. Okay. So you can see actually here there is a integration, we can say, with dermatology and microbiology. So Treponema pallidum, it is a spirochete, and dark field microscope is the microscope which is going to show us the motility of these organisms very clearly. Why? Because these are very slender bacteria. They cannot be observed under normal circumstances under any other microscope. Only dark field microscope is going to help us. Okay, so Shankar is the primary syphilis caused by Treponema pallidum. The incubation period is around 9 to 90 days. So these are the characteristics of the ulcer. Ulcer is going to be single, painless, indurated ulcer, which will have a clean base. If you try to press, there will be only exudate which will come out. There will not be any pus, or there will not be any dirty necrotic base. And this is not going to bleed easily on touch. And dark field microscopy, this is a technique used to observe unstained samples, causing them to appear brightly lit against a dark, almost purely black background. That is the reason why it is called as dark field. The background is going to be completely dark, and here you are able to see these Treponema pallidum, which will have, if it was a moving, you can observe the movement is defined as corkscrew motility. It is defined as corkscrew motility. Okay. And not only dark field microscope, but also phase contrast microscope. Phase contrast. This also can be used to observe the Treponema pallidum. Okay, now please try to answer this question. Migrant laborer with complaints of so friends, can you tell me where was this term actually bubo was given? Was bubo actually there in any of the question? Because I have not got any such question. So Dr. Kartavya Patel, vector was asked for buboes. Can any student remember what is this buboes question? Because this is the first time, to be honest, I am listening that a question on bubo was actually asked. Yes, different question. Okay. But I am glad that almost all of the students have answered this question right. So as I have told you, IV drug abusers, male, commercial sex workers, truck drivers, or not only that, sex tourism can also happen. In one of the FMG exams, it was mentioned that a person has gone to Thailand. Okay, this kind of clues are also given. Migrant laborers. Okay, all of these actually will be very high risk behavior individuals who are going to get sexually transmitted disease. It can be urethritis, or it can be ulcer, or it can be bubo, so, or it can be genital warts. And there is a complaint of urethral discharge after 1 week of unprotected sexual intercourse. So if you observe, this was the picture which most of the students told that came in the actual exam. So if you look carefully, this you are able to see that there is a frank purulent discharge which is there, purulent discharge. And this kind of a frank purulent discharge, whenever you get to see, the straightforward answer is going to be gonorrhea. It is going to be gonorrhea. Okay. Among the given options, the ureaplasma, urea laticum, trichomonas, these also are associated with urethritis, but it is non-gonococcal urethritis. Okay. Urethral discharge in males it is of two types, okay, gonococcal and non-gonococcal. So in the gonococcal, obviously Neisseria gonococcus is the causative agent, whereas in non-gonococcal urethritis the most common organism is Chlamydia trachomatis. Of course, Ureaplasma, Urelyticum, Trichomonas vaginalis, Mycoplasma genitalis, all these are also there as a minority organisms. And if you look at the clinical features, you can observe that in gonococcal urethritis the patient is going to have a severe constitutional symptoms, that is fever, arthralgia, myalgia, joint pains, all this will be there, and along with that there will be severe dysuria, that is painful micturition will be there. And here the incubation period can be from a range of 2 to 5 days, or we can say even 1 week, okay, whereas in the non-gonococcal urethritis the incubation period is going to be little bit longer, 1 to 2 weeks. And most importantly, the difference is the gonococcal urethritis is going to produce a frank purulent discharge, and this discharge is going to be so much excessive that in our viva actually we the examiner asks us if patients undergarments are getting drenched in the pus, so what could be the reason for that. So you can remember that gonococcal urethritis is responsible for excessive amounts of the urethral discharge, whereas non-gonococcal discharge is going to be very minimal, scanty, and it is mostly going to be only serous but not frank pus, okay. So these are the points which you must remember. And of course in the INI-CET one more question was asked related to this gonococcal urethritis itself. So if you do a gram stain, gram negative diplococci can be seen in the neutrophils, okay. This was a INI-CET question. So this is gonococcal urethritis where we can see frank purulent discharge. So this is Neisseria gonorrhea where we can see gram-negative diplococci intracellularly in the neutrophils. And the treatment in the non-gonococcal, we can give either of this, tablet azithromycin 1 gram or doxycycline 100 mg BD for a period of 1 week. Whereas in the gonococcal urethritis, we can give kit 1 which is going to consist of tablet azithromycin 1 gram or cefixime 400 mg stat. Yes, now please try to answer this question. I think most of the students okay, bubo question, Xenopsella bubonic plague. Acha, okay, sandfly was a different question. Okay, me is telling migrant laborer urethral discharge with burning micturition. Acha, burning micturition is also given. Thank you so much, me. So if burning micturition is given, that is going to add up to one more clue that which is in favor of gonococcal urethritis. Why? Because in gonococcal urethritis, patient is going to have excessive pain during micturition, that is dysuria. Yes, so I can see most of the students are giving the answer, and I hope the question is correct. So female, she is anxious to conceive and complains of profuse white discharge per vaginum for 2 days, which was painless, non-foul smelling, non-itchy. That is simply telling there was no complaint, that means as such in the patient, only she was able to observe that the discharge was there, and her last menstrual period was 13-15 days back. What is the diagnosis? Okay, this question is not right, I don't remember non-itchy. Okay, so Hamza Jamal says that itchy. So the question was itching present or absent, because this is going to make a lot of difference. So friends, can you tell me, was itching present, or was it mentioned that the discharge was not associated with any itching? Itching absent was there. Okay, itching absent. So I can see maximum students are telling that non-itching, itching not there. So I have to go with the maximum students. So it is non-itching. Okay, so literally speaking, she was having some discharge which was absolutely not having any symptom whatsoever. Okay, so this is this is actually a seemingly tricky question, because many students have actually answered it to thinking that it is some form of pathology. But if you look at this particular chart, you will understand that this is actually a physiological discharge. Okay, So where is my this thing? I am not able to. 1 second. Yes. So vaginal discharge, candidiasis, trichomoniasis, and bacterial vaginosis. So these are the three causative etiologies for vaginal discharge. So if we look one by one at these, we'll understand that out of these three, only trichomoniasis is a sexually transmitted disease. So this is number one point, which all of you must remember. So that is the point. And in the case of candidiasis, the discharge is going to be given as white curdy discharge. White curdy discharge. So this will be given in the question, and in the case of trichomoniasis, it will be mentioned as green frothy. Green frothy discharge. Whereas in the case of bacterial vaginosis, it is going to be mentioned as fishy odored discharge. Okay, so this is what will be given in the question, and it will be usually serous type of discharge. Okay, and coming to pH, in the candidiasis, the most important thing which you must remember is the pH is going to be less than 4.5. That is, candida can survive in the acidic pH, whereas the other two, they are going to only survive if the pH is basic, comparatively basic, that is more than 4.5. And coming to the symptoms now, so if you look at the candidiasis, the discharge is going to have a, there will not be any foul smelling, but the patient is going to have itchiness. So itching will be there near the genitalia. And coming to trichomoniasis, the patient is going to not only have itching, but also there will be foul smell coming out of the discharge. Okay, whereas in the case of bacterial vaginosis, 1 second. So the patient is not going to have any kind of itching. Why? Because bacterial vaginosis, it is actually a non-inflammatory. It is a non-inflammatory process. It is a non-inflammatory process. The only problem in the case of bacterial vaginosis is that there is going to be an altered microflora. Alteration of the microflora will be there. Alteration of microflora, because of which lactobacillus is going to reduce, the other ones, Gardnerella, Prevotella, Mobilancus, they will be increased in numbers. So it is a non-inflammatory process, so itching will not be there. And here also there is going to be foul smelling discharge. So fishy odor or foul smelling, you can remember. And per speculum examination, we can see in the trichomoniasis, the cervix is going to have inflammation. Okay, cervix is going to have inflammation. Whereas in the case of bacterial vaginosis, there will not be any inflammation. No inflammation will be there. No inflammation. And if we do a KOH, in the case of candidiasis, we can see pseudo hyphae. Pseudo hyphae can be noted. Whereas in the case of trichomoniasis, KOH is going to show whiff test positivity. Whiff test positivity, and even in bacterial vaginosis, whiff test can be positive. Okay, you must remember this. And if we do a wet mount, so in the case of candida and trichomoniasis, what will be the features in the wet mount? Yes, can anyone tell me? So in the case of bacterial vaginosis, please remember it is clue cells which will be present in the case of wet mount. Okay. So few students are actually asking if so 1 second, is sir physiological will profuse it? Yes, Abhishek, physiological there can be associated profuse discharge. Normal discharge is scanty only. Yeah, it can be profuse. Okay. History of infertility was there. Yeah. Okay, history of infertility was there in the question, so that is one more given thing. So bacterial vaginosis, so it was mentioned that it is not foul smelling, but here in bacterial vaginosis, this the discharge is going to be foul smelling. So that is the reason why bacterial vaginosis is not the apt answer. If at all the question did not mention, that the discharge was foul smelling. Okay, yes, clue cells can be seen, and about smell wasn't given. So was foul smelling given or it was not mentioned? So please, friends, tell me about this thing. No mention of the smell. Okay, given, not given. Hmm, given. So if only non-itchy was given, I'm 100% sure. So actually, I'm getting many many types of this thing. I'm getting that it is given, and a few students are telling it is not given. It was unmarried since 4 years. I think it was not having any children. I think infertile, non-itching, profuse discharge with itching also. Smell not mentioned. I think most of the students are telling that if foul smelling is not mentioned, if at all it was not mentioned, then possibility is there. It could be even bacterial vaginosis. Okay, so if at all it was not mentioned, then it could be a possibility that it can be bacterial vaginosis. But because I got this as a majority in the group when I asked, so that is the reason. Foul smelling, non-foul smelling, I thought it was physiological. Okay, so once also confirm with gynec, because this could be somewhat tricky. If the question slightly changes, then the answer can change. Okay, yes. It was false. Okay, fine. Yeah, now please try to answer this question. This is repeated n number of times almost, and even in this INSET also this question was there. Yes, okay, so this always happens, some students, and I hope this is very straightforward question. No need for everyone is with the right answer. I am very glad. So a patient of 30 years came with flaccid bullae on her skin which are easy to rupture. So that is the reason why they are flaccid bullae, easy to rupture. Biopsy revealed suprabasal split. So our diagnosis is going to be pemphigus vulgaris. Pemphigus vulgaris. Okay. Pemphigus vegetans. Okay, pemphigus vegetans. This is a rare variant of pemphigus vulgaris. But in this, there will not be any bullae as such. There are going to be vegetating lesions. Vegetating lesions will be there. Vegetating lesions will be there. And usually this is going to mainly affect vegetating lesions, and this is going to mainly affect the flexures. Like for example, in the axilla. Okay. So it is mentioned flaccid bullae. So this can't be the answer. And foliaceous is going to have subcorneal split. Subcorneal split. Okay, I will show you how we can differentiate pemphigus foliaceous and vulgaris. Erythema multiforme, it is basically discussed in the drug reactions topic, where the pathognomonic lesions, that is target lesions can be seen. This is one point. And the most common infectious cause for erythema multiforme is herpes simplex virus infection. So this was the November 2018, and also this was the INSET 2021 exam question also, where row of tombstone appearance was mentioned in the image and also in the question. And yes, our diagnosis is pemphigus vulgaris, where you are able to see this is stratum basal layer, stratum basal. and you are able to see suprabasal split. So one second. So we are able to see this beautiful suprabasal split. So here you are able to see suprabasal split. And yeah, this is what you must remember. So in the skin, if you look at the layers, the from the superficial till the deep, we have all the stratum corneum. So stratum corneum, stratum granulosum, stratum spinosum, and stratum basal. So these are the layers from top to bottom. And if you observe carefully, I have written the disease names, that is pemphigus foliaceus at the top and pemphigus vulgaris below. So in the pemphigus foliaceus, I hope all of you know that desmoglein first, that is desmoglein 1, is going to have, that is the antigen against which antibodies are going to be produced. And in, if you remember the mucosa, in the mucosa, desmoglein 3 is present, whereas desmoglein 1 is absent, and this is the reason why pemphigus foliaceus is going to spare the mucosa. And if you remember, there is a differential arrangement of these desmoglins. In the upper epidermis, upper parts of the epidermis, desmoglein 1 is more concentrated, whereas in the lower parts of the epidermis, desmoglein 3 is in more concentration. Desmoglein 1. So because of this, in pemphigus foliaceus, there is going to be a split in the subcorneal layer, that is in the stratum granulosum exactly. Whereas in the case of pemphigus vulgaris, the split is going to be just above the basal layer, that is exactly in the stratum spinosum layer. Stratum spinosum layer. And in pemphigus vulgaris, mucosa is going to be involved in almost 90 to 95% of the patients. Okay, now please try to answer this question. Yes, Niranjan Kumar, the answer is pemphigus vulgaris. Okay. So Arhan, pemphigus, they should give oral mucosal. So no need. So flaccid bullae is already mentioned, and suprabasal split. So these two I have asked the students. They told that these two are mentioned. So if these two are there, definitely pemphigus vulgaris is the only option which you can mark. And yes, all the students, so if you have watched till this point and if you like this explanation and these questions, if you feel that these are exact questions which are asked, please do remember to give a thumbs up for this question when you are watching. Okay, so that YouTube will understand, the algorithm will understand that this is actually a useful video where the real questions are actually being discussed. So Dr. Neelam Bharadwaj, thank you, not only in the comment section but also in the actual video also. Please do give a like. So a question, so everybody has come up with the right answer. Right. A patient is on MBMDT, multibacillary multi-drug therapy, presented with inflammation over the pre-existing lesions and also nerve involvement. So please tell me whether this pre-existing lesions and nerve involvement, were they mentioned in the question? And students told that this was the exact image, and they told that this was looking something similar to this. Acha, not systemic involved. Thank you so much, Neelam. Yes, not systemic involvement. Acha, that was given, Dr. AB. If not systemic involvement is not there, yeah. So then it is definitely going to not systemic involvement. So if it is mentioned in the question, then it is type 1 reaction, type 1 lepra reaction. And in the lepra reactions, always you must remember that we have to continue the anti-leprosy treatment, that is one thing, and start steroids. Okay, so option C is the answer here. Okay, please remember, if the question mentioned it as type 2 reaction, if the question mentioned it as type, features, if there are systemic involvement and erythema nodosum leprosum like lesions, if it was given, actually then also we have to mark option C only as the answer. Why? Because in type 1 and type 2 reactions, in both of these, we have to continue the anti-leprosy treatment and we have to give the patient steroids. We have to give the patient steroids. Okay, so the treatment is going to be one and the same in both the conditions. So this was actually a question which I asked on 9th of September in the course that is called emergency learning dermatology through emergency MCQ based discussion. And this was also type 1 reaction, but the question which I asked was slightly different. So can you try to give the answer? This was not in the NEET exam, but can you please tell me what is this answer for this question? Edematous plaques on the face over previous hypoanesthetic patches with associated pain since 10 days. It was sudden in onset and tenderness was present. He was on MBMDT. What is your diagnosis? Okay. Yes, so all of you are right. So if this point previous patches are becoming inflammatory, then if it is given, then here you are able to see it is becoming inflamed. Then our answer is going to be type 1 lepra reaction. So lepra reactions are of 3 types basically: type 1, type 2, which is also called as erythema nodosum leprosum, and type 3, which is called as Lucio phenomenon. Lucio phenomenon, which is usually seen in Lucio leprosy. This is having many names: pretty leprosy, beautiful leprosy, lepra bonita. Okay, so we are concerned with type 1 and type 2 lepra reaction. So if you, I hope all of you know this rule of 5, which is very, very important. In type 1 lepra reaction, the underlying hypersensitivity is type 4. And in type 2 lepra reaction, the underlying gel and Coombs type of hypersensitivity is type 3. So if you add 1 plus 4, we are going to get 5, and like similarly 2 plus 3 is going to give us 5. So 5 is the common number. By this you can remember that it is cell mediated immunity or delayed type of hypersensitivity which is playing an important role in type 1 hypersensitivity, whereas in type 2 hypersensitivity, type 2 lepra reaction, it is type 3 hypersensitivity. That is, there are going to be immune complexes which are going to play a key role. So why is it important? Because if you can understand this, the immune complexes, they can get deposited not only in the skin causing the new lesions, but also these immune complexes can get deposited systemically, thereby causing in the joints arthritis, orchitis. Not only this, hepatitis, or, you can imagine the itis, and that inflammation will happen in these patients of type 2 lepra reaction. Okay, so that is the simple logic by which you can remember type 1 and type 2 lepra reactions features. And here in the case of type 1 lepra reaction, because it is cell mediated immunity, the pre-existing lesions are going to have the lepra bacilli which will become inflamed suddenly, that is, pre-existing lesions will become inflamed. And not only that, please remember in the question it was also mentioned that the nerve involvement, that is neuritis, was also given in the question, and neuritis is going to be very much severe in the case of type 1 lepra reaction when compared to the type 2 lepra reaction. Okay, so the drug of choice for both type 1 as well as type 2 is steroids. But you must remember that thalidomide, which is a tumor necrosis factor alpha inhibitor, TNF alpha inhibitor, it is actually the gold standard. It is the gold standard in the case of type 2 reaction. It is gold standard in type 2 reaction. But why don't we use thalidomide? Is because there is a very big problem that it is teratogenic. Okay, one second. Yeah, so it is teratogenic. So we cannot include this in the national leprosy eradication programs or World Health Organization programs. Why? Because even women also can get type 2 reactions, and if this was the drug of choice, then there's a very big problem. We cannot give this to the woman. So type 1 lepra reaction, if nerve abscess is there, incision and drainage should be done, and of course steroid should be given. And type 2 lepra reaction, there are other drugs which can be used, out of which clofazimine is important for you all to remember. Why? Because this is the multi-drug therapy, one of the multi-drug therapy drug which can be used in type 2 lepra reaction. So that is the reason why this is important. Not only that, chloroquine also can be used, and in type 1 even cyclosporin can be used. So I tried to get the options for this question, but actually students were looking at this picture, they have grabbed this answer, clicked on this answer. I think they have not even read the other options maybe. So yes, this is the classical, this is n number of times this question was asked. This is classical Castle's necklace, which can be seen in pellagra. which can be seen in pellagra, which is due to the vitamin B3, that is niacin deficiency. Niacin deficiency, this was discussed n number of times by me on YouTube, on Unacademy special classes, everywhere. Okay. Yes, and this pellagra, it is going to have 4Ds. 4Ds. So one among them is diarrhea, dementia, and of course this classical photodermatitis. So this classical picture, photodermatitis. And previously, historically, these patients used to be missed out, diagnosis was not able to be made, because of which the fourth D, that is death, used to happen. Okay, death used to happen, but nowadays the treatment is very much simple. So it is being diagnosed properly. And can you remember what were the other options? Those students who are watching, can you remember what were the other options, if in case you remember? But whoever I asked, they told that they have not remembered. The only option which they remembered was history of diarrhea, dementia, that is cognitive impairment. So these were ones which most of the students remembered actually. Is anyone able to remember any other option? You can put it in the comment section. Okay. And was this there in the actual exam? This few students told that a patient who is a farmer, works in maize fields, keeps more of the maize as food, which amino acid deficiency leads to the given condition. Okay. Was this question also given along with the previous question, or in this there was no image? What was this? What was the small difference between these two questions? Yes, please, friends. So students told me that amino acid deficiency was asked in this question. Acha, option was niacin. So there were two questions which were asked on the same topic, that is pellagra. Niacin, riboflavin. Okay, if niacin is given, definitely niacin is the answer. Two questions. Oh my god. Some lesions on the neck. Acha. Diet was there along with dementia, diarrhea. Okay. Only niacin is given. Okay. So was this image repeated two times in the actual exam? Okay. Oh, one had history of alcoholism. Okay. Easy questions. Okay. So fine. So this was the previous question which was asked. So again, this is vitamin B3. And you must remember that not only dermatitis affects the neck area, causing Castle's necklace, but also the dorsum of the hands can also be affected by the dermatitis, where we call it as gauntlet sign. You are able to see the dermatitis only involving the dorsum of the hands. This is called gauntlet sign. And yes, this particular tryptophan deficiency or niacin deficiency, this can happen because of so many reasons. This will be discussed in biochemistry in detail, but of course briefly you can say that maize is going to be associated with niacin deficiency. Maize is associated with niacin deficiency, and also those who eat jowar or sorghum as their staple food, because of the presence of excess leucine, the absorption of tryptophan will be hampered, because of which there is going to be niacin deficiency. Why? Because tryptophan is going to ultimately form the niacin. It is going to form the niacin. And carcinoid syndrome and heart nerve disease, and not only that, even persons who indulge in excessive alcoholism, even they will also have this deficiency. And these are the dermatitis, diarrhea, dementia. And so actually this is the pellagra, where dermatitis, diarrhea and dementia will be there. And always whenever you read this topic pellagra, you must also hand in hand read this acrodermatitis enteropathica, which is basically autosomal recessive condition whereby zinc absorption will be defective. And again the same dermatitis, diarrhea will be there, but the third component is going to be alopecia. Third component will be alopecia. So this is a child having acrodermatitis enteropathica affecting the scalp. Eczematous changes are there over the scalp. Peri-orifacial, peri-orbital, peri-oral, nasal, perineal, perianal. Everywhere you are able to see dermatitis changes. Okay, with zinc supplementation, the child is going to improve. Yes, now please try to answer this question. Girl child was presenting with rough surface lesions over her elbows, knees, mainly extensor surfaces, and also had problem in night vision. Few students told that it was night vision, and few students told that blindness was mentioned. Okay, yeah, this is the phrenoderma question. Okay, scurvy radiological feature was asked. Acha, okay, scurvy. So this is actually a question which I have not got to. Okay, night vision, right? So answer is phrenoderma, right? So this is actually a repeat question. Phrenoderma, it is also called as toad skin, where the skin is going to become bumpy, very rough, mainly over the elbows and over the knees. And we can see follicle oriented papules in this phrenoderma. Okay, and you might be wondering that whether only vitamin A deficiency can cause this, or other deficiencies also can be associated with this phrenoderma. But please remember, phrenoderma, it is not only associated with vitamin A deficiency, but in books it is mentioned that even vitamin B, vitamin C, and vitamin E. So all these vitamin deficiencies can cause phrenoderma. Not only that, essential fatty acids deficiency can also lead to phrenoderma. So few points about keratosis pilaris. In keratosis pilaris, the basic problem is going to be a follicle, a hair follicle, which is going to become plugged. So because of which the corneocytes, which usually easily shed off, they will not easily shed off, because of which bump will happen just adjacent to the follicle. This is a papular lesion surrounding a follicle. And clinical features, clinically, where do we see these lesions commonly is over the lateral aspect of the arms, usually lateral aspect of the arms. One second, this, yes, lateral aspect of arms. And can anyone tell me what is the very important association of the keratosis pilaris, which you might have read in dermatology? Very important association is there. Can anyone remember? So you must remember that atopic dermatitis is a very important association of keratosis pilaris. Atopic dermatitis, that is atopic eczema. Okay. Yes, now this is the question which all of you are asking actually. So yes, please tell me, what do you think is the answer for this question? Male child complaining of mild painful boggy swelling in the scalp for 3 months. Pet animals are there in the home. What is the diagnosis? Can you tell me, was this word boggy swelling given in the question actually? Just give me a confirmation. Pet was dog. Okay, pet was dog. Okay, boggy swelling was not given. Pet is actually a dog which was given in the question. Okay, no boggy. Okay, fine. So even in such case, if a question mentions that a child is coming with a swelling over the scalp for such a long duration, for almost 3 months, so it is a chronic condition. It is a chronic condition whereby a swelling is there. And also one more clue is given, that is dog, which is going to tell us that some kind of zoophiliac fungal infection, that is dermatophytic infection may be there associated. So the chirion is going to be the answer here. Okay, image is the same, you are correct. Okay, image is the same. Okay, so zoophiliac organisms are usually, most commonly, you must remember trichophyton, mentagrophytes, and verrucosum. Okay, in the next slides I have put up this. trichophyton, mentagrophytes and verrucosum. Okay, so yes, you must remember that zoophilic, these dermatophytes are going to affect animals primarily, and whenever these dermatophytes infect humans, then there is going to be a massive inflammatory response, okay. So what are those important ones? They are trichophyton, which you must remember, verrucosum and mentagrophytes. And if you observe carefully, these two are associated with very important inflammatory variety of tinea capitis, which is chirion, where we can see a boggy variety of swelling, along with a regional lymphadenopathy can be seen, occipital lymphadenopathy, and the hair are going to be very easily pluckable hairs. And as you can see, the causative agents are trichophyton, mentagrophytes and verrucosum. Okay, so our answer for this question is chirion. And of course, treatment, the drug of choice is griseofulvin, which is a fungistatic drug. Whereas if the question mentions the trichophyton as a causative organism, terbinafine will be the answer. So T for T. Yes, now please try to answer this particular question in the comment section, friends. Yes, mentagrophytes. Okay, that question is coming up. Yes, friends, please try to answer this question in the comments. What do you feel is the answer for this? 23-year-old female primigravida whose school-going cousin staying in the same house contracted varicella infection. Patient approached medical center. Testing of varicella antibody is negative. So many students told me that it was mentioned as varicella antibody being negative. So, so out of this pregnant woman, this primigravida, what is the correct statement in this particular question? That acha, nephew, okay, fine. Sorry for that. What was answer for the? Okay, thank you, nephew. Okay, noted. Fine. Antibody negative. So when antibody negative is mentioned, that simply means that this, you know, this 23-year-old primigravida woman, she did not see this varicella zoster virus. It is going to produce primary infection in the form of varicella, which is called as chickenpox. Varicella, or the other name for this condition is called chickenpox. And if a person gets this varicella or chickenpox during the childhood, the varicella zoster virus, it is going to be lying dormant in the dorsal root ganglion. And if there is any trigger in the adulthood, it's like stress, like for example exam stress or immunosuppressive agents or any surgery, then what will happen? These viruses, they are going to reactivate and produce a condition called as herpes zoster. I will show you how the images look like. So if this primigravida, if she had developed this varicella during her childhood, if she would have developed, the varicella antibody would have been positive in her. Antibody would have been positive in her, whereas it is mentioned negative. So if this a nephew, if she gets in contact with this nephew who is having varicella, yes, she is going to be susceptible to chickenpox. All of you have answered this question right. Okay, and so this will become little bit lengthy, so let us quickly see. These are all the other things. Hair perforation test is positive in. Okay, so these were the options which I got. Okay, now I am getting some different answers here. So some are telling A, some are telling B. Okay, now maximum students are answering it as option A. Can you tell me what was the option 4 which was given, option D which was given in the question? Okay, Darshan MK is telling image was there. Acha, image was there. Okay, fine, noted. So microsporum gypsum was in the option. Thank you so much, Kaushik Reddy. Microsporum gypsum. Its image showed Kirion like acha microsporum gypsum. Okay, fine. So out of the following given options, trichophyton mentagrophytes is the answer. So what is this? Is basically dermatophytes. To differentiate, this is actually hardcore microbiology topic, but since it was asked, I got hand on this question. I am discussing this. Okay, so trichophyton, mentagrophyte and its variants. To differentiate these, we use this particular hair perforation test. So what we will do is we will autoclave some prepubertal pubertal hair, and we will autoclave it, and sterile distilled water family will be added into a vial, and the hair will be put in the vial, and we will inoculate small fragments of the test fungus. So the test sample in which we don't know what is the actual cause, dermatophyte, we will add that and we will incubate it. Individual hairs are removed at intervals of up to 1 month and examined microscopically in LCB, lactophenol cotton blue. Isolates of trichophyton mentagrophytes produce marked localized areas of pitting and marked erosion. Okay, so this is the picture. So this is the hair follicle 1. This is the hair follicle 1. 1 second. So this is hair follicle 1, and this is the hair follicle number 2. So if you look, the hair perforation test is negative in this case, where the hair is absolutely intact, whereas here the hair perforation test is positive, where we can see these wedge shaped perforations created in the hair. Okay, so this is what is called as hair perforation test, and it is positively seen in the case of trichophyton mentagrophytes. Trichophyton mentagrophytes, and that is the answer here. Okay, so that was it in this session, friends. So, and I hope all of you have actually enjoyed this particular discussion part. Please do give a thumbs up if you really like this session. Despite I know there may be a few students who might have answered wrong, or maybe in the given questions, some language may be different in the questions which I framed. Okay, so extremely sorry for that, because this was what my students actually gave me the questions. Maybe somewhat here and there some differences may be there. Total how many? So Rajkumar actually, so we can say exactly from the dermatology, can say some 10 to 12 questions were there, but I can say the integration was so deep that we cannot actually pinpoint this is derma, this is micro. Okay, that's what I observed, but the questions were actually superficial, but the integration part was so deep. And yes, a small discussion about the plus subscription. So if you are unaware, and yes, as I have initially told you that please do not stop your momentum, continue the momentum, and I would suggest you to take some break, have a small nap, have a break of how much ever you feel is apt for you, but I would suggest you to continue with the INS-CT preparation, and because the results definitely they are going to take a lot of time, and counseling process is going to again take a lot of time by the time which INS-CT exam is going to be conducted. So definitely I would suggest you to continue your momentum, however this much far you have come. So, and also I have told you initially that because there is going to be a cutthroat competition definitely this time. Why? Because many students told me that this particular question paper was doable, kind of doable type of question paper. So whenever this kind of a question paper comes, so one mistake is going to land up, one mistake is going to make a lot of difference, even thousands of ranks of difference can happen. So that's the reason why you must continue in INSCET, and because seats in INSCET are also a good number of seats are there. Okay. So, and I wish that in this particular exam you are going to rock the exam, and please do remember and try to give these kind of wonderful testimonials which previous batches of INSCET and FMG students actually gave to me. Okay, and small announcement from the Unacademy. Yes, INSCET 2021 batches are going to start from September 15th onwards. September 15th, the classes are going to be evening classes mainly from the 15th. And also there are batches for clinical examination and procedures for mainly university exams, we can say university. If you are having any juniors, who are in the foreign FMG or anywhere in the India, so please do let them know that for university exams this is going to be very very helpful for the practical exams. And not only that, target next 2022 is also going to be started from 15th of September. So all these batches are starting from 15th of September. And not only that, FMG batch is also going to start from 15th of September. And yes, target next 2023 is starting from 22nd of September. Okay, and target next 2022 evening batch is going to start from 8th of September. And there is one more very good news, we can say, that 4-year subscription, the cost for iconic subscription, where you are going to get not only Unacademy but also you are going to get Prep Ladder. So you can take up the subscription of both Unacademy as well as Prep Ladder for a period of 4 years. If in case you are in your second year or third year and watching this, and if you are having any colleagues, juniors, please do let them know about this 4-year subscription. Okay. And yes, 12+2 is also a limited period offer. Please do find out if this offer is there, or if 24+4 is the new offer which is running right now. And these are the charges for the subscription. So plus subscription is going to give you only Unacademy, whereas iconic subscription is going to give you Unacademy plus Prep Ladder. Okay, what are the advantages? So in iconic you are going to get both Unacademy and Prep Ladder, and I can tell you that almost Unacademy subscription is a free with Prep Ladder for iconic subscription. Why? Because the charges are almost same like that of a Prep Ladder. But here you are also going to get well structured live classes of Unacademy, and recorded classes also can be watched, and 25,000 plus questions of Unacademy can be accessed. So this access is going to be unlimited. Okay, you can access all the resources and comprehensive printed and digital notes. Yes, the digital notes are also going to come up. And one more reminder, actually, those students who are taking up the plus subscription, today is the last day. Today is the last day for you to take up the plus subscription. And after getting this plus subscription today, which is the last day, you are going to get printed notes of Unacademy. Printed notes of Unacademy, you are going to get this at the cost of the plus subscription itself. Okay, whereas from tomorrow onwards the cost of plus subscription is going to increase on the the only reason for that is because printed notes are going to be added. But this day it is a offer, we can say, from Unacademy team. From tomorrow onwards the plus subscription charges are going to increase. So if you wish to take up the subscription, all you need to do is apply the referral code DRMSD, or the links for the code will be there in the description box below, or just you need to enter DRMSD when you are entering the referral code section here. Then you are going to automatically get the off, which is the maximum offer which you can get in this Unacademy. And yes, you can scan these QR codes if you have downloaded Unacademy app already, Unacademy learner app. And if you scan these QR codes directly, you will be taken to these lectures, that is NEET PG 2020 questions, 2019 questions and 2018 questions. All of them you can watch them. And yes, any more suggestions, any more questions which you all feel was actually asked? So thank you so much, Dr. Sunita Tiwari, for the appreciation. In question, for her nephew, antibody is negative. Dr. Priyamurthy, but it was given that nephew had developed varicella, then how can it be negative? So the other students who are watching, can you tell me, Dr. Priyamurthy, no, yeah, Dr. Priyamurthy, whether the nephew had negative antibody, was it given in the question, or was the antibody levels were pertaining to the primigravida woman? So yes, I will add the questions here. Bubo. So Darshan MK, this Bubo question, what were the options? So I remember few students told me plague and what else? Yes, primigravida, I guess. Okay. Yeah, I also thought that same thing. Why? Because it doesn't make a sense that if you got varicella and antibody are negative. So I'm not sure. Maybe it can happen many times. So reading 200 MCQs in itself is a humongous task, and all of you have actually done that. Really well. So first of all, you must pat the back of yourself, and you can say that you are all great. Why? Because discussing these many few of the questions in dermatology itself is a big task, and I can imagine you have read 200 questions. Romanchit Upadhyay, non-itchy was given. Oh, okay. Negative for antibody, that was given. Okay, fine. And this non-itchy and foul smelling, please once try to confirm with the gynae faculty also, ops gynae faculty once. Okay. Ixodes tick. Okay, Ixodes tick. So what was the question related to Ixodes tick? Can you tell me, Dr. Darshan? Bubo, heart tick. And those students who are watching, please, if you have not yet liked this video, please, 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 friends, do give it a like. So do not leave this question without giving a like. So same Bubo heart tick. So Darshan MK, I did not get the actual question. Plague, heart tick, same Bubo questions, options, sir. Acha, Bubo questions. So for this, options were heart tick, Ixodes tick. Were these options? So actually students have not discussed because maybe this was not having any derma component in that maybe. Kala Azar. Okay, leishmaniasis question was asked. Yes sir, options for Bubo. Acha, options. These were options for Bubo. Okay. And one more thing. So in Unacademy, so there is this Telegram group of Unacademy. So please join in that, and you can tag me in that Unacademy Telegram group. The link will be there in the description, so you can join that and you can tag me, and I am there available. You can tag me and you can ask me any dermatology related questions which were asked. Okay. Okay. So any more? These were actually the questions which were discussed. Those students who have missed out. What is this? Fine. This was not having any controversy. So Pellagra, two questions were asked. So that is something really very interesting. Questions options: Xenopsilla chopis, Ixodes, sandfly. Acha. Okay. Okay. So this was the one question which was actually slightly tricky. So rest were all straightforward questions without any queries. And if any more questions I would get, then those questions I will try to cover those questions in tomorrow. There I will keep a special class, and in that I will try to cover the rest of the questions which are related to dermatology or integrated with dermatology. So these I will try to cover in the tomorrow's special class. Most likely I will take a special class. Okay. Yes, friends. So let us call it a day, because you might be a lot. Uh, so you can check out what are all these things given, and I will try to post this as a PPT or a PDF in the Unacademy Telegram group about which I told you. Yes, just download the Unacademy Learning app. It is there in both Android and iOS. And also, please do subscribe to this channel, and put any of your queries in the comment section after this video is taken. It is not live anymore. You can put the in the comment section. You can ask any of your query, and please do like this video, and of course share it with your close friends. Okay, so that they will understand what mistakes they have done, or what are the correct answers in dermatology they can get to know. Okay, so like, share, comment, and of course subscribe, and also hit that bell icon. Okay, so that you will get all the notification of the videos which will be of Unacademy. Okay, thank you so much for all your active participation and patient listening, because of which this session was very energetic. Otherwise it would have been very boring at this time. And also all the students are actually very energetic, and they are all you are all actually super students, I can say. Why? Because writing a 200 question and MCQ based exam in the morning and coming again for this discussion is really tough, and I appreciate all of you. You are all awesome. Okay, and I pray, I hope that you are all going to get whatever you wanted. All the seat of your choice, branch of your choice, and also state of your choice. Okay, thank you so much. Thank you so much, friends. So that's it in this session. Bye bye. Happy learning dermatology. Sarve jana sukhino bhavantu. Bye.